Welcome to Fertility Doc Talk. I'm your host, Dr. Kaajal Abrol. I'm a board-certified obstetrician-gynecologist and fertility physician based in Toronto, Canada. My goal is to educate patients, partners, and the public on fertility and to destigmatize infertility. Through this podcast, I aim to increase knowledge and awareness about reproductive health to empower people to make informed decisions about their own fertility. Welcome everyone. In this episode, we are going to review the basics of fertility treatments. I often hear people say they don't know too much about fertility treatments and what all of the options are. So let's take some time to discuss the various treatment options available and when they may each be applicable. Once you have completed a fertility assessment, you can discuss and consider your treatment options with your physician or healthcare provider based on your results and your family planning goals. When I meet with patients, I like to start by dividing treatment options up into three main paths. 1. Ovulation induction. 2. Controlled ovarian stimulation. And 3. In vitro fertilization. Ovulation induction is when fertility medications are used to help mature and ovulate a single egg in people who do not ovulate regularly. Medications used for this include oral medications or tablets, such as clomiphene citrate or letrozole, or injectable medications, which is injectable FSH hormone and sometimes also LH hormone. The medications are started early in the menstrual cycle, usually starting on day 3 or 4. The oral medications are taken for 5 days generally, while the injectable medications are taken daily until ovulation, so usually around 10 to 14 days in total. The cycle is monitored with serial bloodwork and ultrasound every few days to look at ovarian follicle growth, blood hormone levels, and uterine lining. This is referred to as cycle monitoring. As the follicle grows and the egg inside of it matures, the estrogen level in the blood should rise, and the uterine lining should thicken on ultrasound. Ovulation may occur on its own, or it may be triggered with an injectable medication, which is an HCG or human chorionic gonadotropin injection. HCG is similar in structure to LH or luteinizing hormone, the hormone in the body that triggers ovulation. So an HCG injection can be used to help trigger ovulation in a fertility treatment cycle. Controlled ovarian stimulation, also sometimes called controlled ovarian hyperstimulation, is when fertility medications are used to help stimulate the ovaries to mature and ovulate a few eggs, ideally 2 to 4. The idea is to increase pregnancy rates by ovulating more than one egg in an individual who already ovulates regularly, so they already release a single egg every cycle. Medications used for this include oral medications or injectable medications. These are the same medications used for ovulation induction, but often at a slightly higher dose. Once again, these medications are started early in the menstrual cycle, around day 3 to 4, and continued for 5 days for oral medications and right up until ovulation for injectable medications. And cycle monitoring is again used to monitor the response to the stimulation medications and the timing of ovulation. Once ovulation occurs in an ovulation induction or controlled ovarian stimulation cycle, there are 2 options to try and get sperm to meet egg. 1. Timed intercourse, or 2. Intrauterine insemination, or IUI. Intrauterine insemination is where a sample of sperm is washed and processed to remove any debris and concentrate the good motile sperm. The good quality sperm are then placed in the uterus, so that they are one step closer to the egg, compared to intercourse, where sperm is ejaculated in the vagina and must make its way through the cervix and rest of the uterus and then into one of the fallopian tubes. With IUI, the sperm must still make their way from the body of the uterus into one of the fallopian tubes, but they are closer. The actual IUI procedure starts with your healthcare provider inserting a speculum into the vagina, similar to a Pap test. A tiny catheter is then placed through the cervix and the sperm is injected into the uterus. This procedure takes just a few minutes to complete and is not painful. Let's now talk about indications for these treatment options discussed so far. Ovulation induction is indicated for people who have irregular or no cycles, so they do not ovulate regularly or predictably. Controlled ovarian stimulation is for people who do have regular cycles, so they do ovulate regularly, but they have not yet conceived. It helps to increase pregnancy rates by increasing the number of mature eggs that are ovulated in a cycle. IUI is indicated for a few reasons, with either ovulation induction or with controlled ovarian stimulation. This includes mild sperm factor fertility issues, so a slightly low concentration or motility, or both, ejaculation or erection issues, the need for donor sperm, and unexplained infertility, where an obvious cause for fertility challenges has not yet been identified. Occasionally, IUI may be used in a natural cycle, meaning medications are not used to help produce additional follicles in the cycle. This may be indicated in cases where there is a significant issue in sexual functioning preventing intercourse, for example, severe erectile dysfunction or significant vaginismus, or in cases where donor sperm is needed. It isn't really ideal in most other cases of infertility, as IUI alone will minimally increase pregnancy rates above trying to conceive on your own with intercourse. The next treatment option available after ovulation induction and controlled ovarian stimulation is in vitro fertilization, or IVF. IVF is a process in which the ovaries are stimulated to produce a number of mature eggs. The eggs are taken out of the body and fertilized with sperm in a lab to create embryos, and the embryos can then be transferred into the uterus, usually one at a time, to hopefully implant and develop into a pregnancy. Similar to ovulation induction and controlled ovarian stimulation, cycle monitoring is used in IVF to monitor the response to the stimulation medications and the timing of the egg retrieval procedure. Common indications for IVF include unexplained infertility, unsuccessful with more conservative fertility treatment like controlled ovarian stimulation and IUI, low ovarian reserve, sperm factor fertility issues, especially if moderate to severe issues, endometriosis, a genetic condition requiring testing of embryos, and fertility preservation, meaning embryo freezing for medical or non-medical reasons. So these are the basic categories for fertility treatment: ovulation induction, controlled ovarian stimulation, IUI with either of these, and then IVF. In addition to these treatment options, there are some additional options and treatment add-ons that may be considered. Donor egg IVF is where another individual with ovaries undergoes IVF, and then their eggs can be fertilized with a partner's sperm or donor sperm, and that embryo can then be transferred into a patient's uterus. Donor egg IVF is indicated when egg quality is a significant issue, or when ovarian reserve is very low, or for a single patient who was assigned male at birth, or a couple where both partners were assigned male at birth. Donor sperm can be used with the treatment options mentioned, IUI or IVF. A sample of sperm from an individual with sperm can be used for insemination or for fertilization in IVF. Donor sperm is indicated when sperm quality is a significant issue, or for a single patient who was assigned female at birth, or a couple where both partners were assigned female at birth. A gestational carrier or a gestational surrogate can be used to help carry a pregnancy once an embryo is made through IVF. Some indications for needing a gestational carrier include a serious medical condition that could be worsened by pregnancy, or a medical condition that is an absolute contraindication to pregnancy, absence of a uterus, either from birth or acquired at some point, a biological inability to carry a pregnancy, for example, a single patient who was assigned male at birth, or a couple where both partners were assigned male at birth, or a history of multiple failed embryo transfers, or recurrent early pregnancy losses where there is possibly an undiagnosed uterine issue playing a role. Another treatment option is where fertility treatment is done for fertility preservation. In these cases, the individual or couple is not actively trying to conceive, but rather wanting to preserve their fertility for the future. Sometimes this is for a medical reason, such as a cancer diagnosis and cancer treatment. Other times, it's for a non-medical reason, personal, professional, or educational reasons, for example. This may involve IVF with embryo freezing, so the ovaries are stimulated, the eggs are removed from the body and fertilized with sperm, and the embryos are grown in the lab and frozen for later use. This could also involve egg freezing, so the ovaries are stimulated, the eggs are removed from the body, and the mature eggs are frozen without being fertilized by sperm, so they can be fertilized and used at a later time. Finally, a treatment add-on that may be considered when doing IVF is pre-implantation genetic testing, or PGT. PGT is a screening test that can be performed on embryos created via IVF to genetically analyze the embryos prior to transfer. There are two general types of PGT, PGT-A and PGT-M. PGT-A analyzes embryos for the correct number of chromosomes, the DNA molecules that hold your genes or the genetic information for your body. By identifying embryos with the correct number of chromosomes, the idea is to reduce chances of a failed implantation and reduce the chances of a miscarriage. PGT-M analyzes embryos for a specific genetic condition that has been identified in a family, one that is caused by a defect in a single gene, not a group of genes. Now let's take a few minutes to go over some common questions I hear about fertility treatments to understand the treatment options better. First, a very common one I hear is, will fertility treatment give me twins? Multiple births, so twins, triplets, possibly more, are common with fertility treatments, but it's important to discuss what treatment this applies to and why. Commonly, people think IVF often results in multiples, but actually, the risk of multiples can be limited or reduced with IVF by transferring a single embryo at a time into the uterus, thereby reducing the risk of more than one embryo implanting in the uterus at once. The risk of multiples is actually less controlled with medicated IUI treatment, meaning controlled ovarian stimulation and IUI, where the ovaries are stimulated to mature and ovulate a number of eggs, which then have the potential to be fertilized with sperm and implant in the uterus all at once. Another question and concern I often hear is, what are some of the common side effects of fertility medications? And will the fertility medications make me gain weight? Some of the common side effects reported from fertility medications include headaches, bloating, breast tenderness, and mood changes or mood swings. Tiredness is another commonly reported side effect. Weight gain is a common concern I hear about. High estrogen levels from fertility medications, especially during IVF, can cause some fluid retention and weight gain, but it is temporary. And there are other factors that can lead to weight gain during fertility treatment. It's not all due to fertility medications. For example, the stress of infertility and fertility treatments can lead to poor eating and weight gain. As well, patients are often advised to reduce their physical activity during fertility treatment, especially during IVF, which may also contribute to weight gain. An interesting question I sometimes hear is, do I have to do treatment in a certain order? Or asked another way, do I have to do controlled ovarian stimulation and IUI before IVF? The short answer is no. There is no specific order in which you have to do fertility treatment. When there isn't a specific medical indication to move to IVF right away, it is not uncommon to start with controlled ovarian stimulation and IUI in an effort to increase pregnancy rates above trying at home on your own, but also be more conservative, and avoid IVF. It is generally accepted to move on to IVF after 3 to 4 cycles of controlled ovarian stimulation and IUI, although up to 6 cycles may be recommended in some very specific cases. That said, other non-medical factors may also play a role in decision-making. For example, insurance coverage for different treatment options. Some insurance companies in the US, for example, may not cover IVF unless a certain number of IUI cycles have been completed first. In Canada, cycle monitoring for IUI cycles is not always covered under provincial health insurance, depending on the province, making IVF a better option given its much higher pregnancy rates in most cases. Sometimes, patients will move from doing IVF to doing medicated IUI cycles because their response in IVF was very low, limiting their overall prognosis. So while moving from controlled ovarian stimulation and IUI to IVF is a common stepwise approach that is taken, it is not necessarily the best path for you, for medical and non-medical reasons. Lastly, probably one of the most common questions I get when planning IVF treatment is, will I go through menopause faster if I do IVF? Rest assured, you will not go through menopause earlier because you did IVF. But let's understand why. Every month, a group of immature eggs come from deep within the ovaries to the surface of your ovaries. These eggs sit in little sacs of fluid called follicles, and they are referred to as antral follicles or resting follicles. In a natural cycle, one of these follicles responds to the follicle-stimulating hormone from the brain, and the egg within the follicle develops and matures. The remaining antral follicles die off, a process called atresia. In an IVF cycle, the goal is to make use of many of these antral follicles and the eggs that are held within them. FSH injections are given to help develop and mature multiple eggs at once. So IVF is not using up more of your eggs in a single cycle, leading to early menopause. It is simply trying to mature and make use of eggs that would otherwise not get used and die off. So there you have it, an overview of the fertility treatment options available, from ovulation induction and controlled ovarian stimulation with IUI to IVF. It's important to understand what options are available and the indications for each of these, so you can work with your healthcare provider to decide what options are right for you. I hope this episode was useful in allowing you to better understand all the various fertility treatments and how they can help you reach your family planning goals, now or in the future. That's it for this episode of Fertility Doc Talk. I really hope you enjoyed listening and learning and feel empowered about your reproductive health. If you enjoyed this episode, please remember to subscribe to the podcast and tune in to our next episode.